So thank you for attending the session today. So today I'm going to give a brief introductory session on admission avoidance and frailty in dementia care. My name is Kerry Lyons. I am the consultant Admiral nurse for frailty and physical health at Dementia UK. So the session today focuses on frailty and admission avoidance, alongside offering a consideration of potential opportunities in your role to influence best practice around frailty and dementia. So within today's session, I will cover an understanding of frailty in dementia. We will talk about the impact of hospital admissions. I will cover a range of strategies for admission avoidance and talk about management of frailty in dementia, and we'll eventually talk about collaboration and support. So to start with a recap of what we already know about dementia and frailty. So dementia is not a normal part of aging. Dementia is a life-limiting condition, and there is no treatment available to cure dementia or to alter its progressive course. Dementia and frailty often accompany one another in older age, and dementia is now recognised as a palliative illness. And once diagnosed with dementia, you will either die with or of dementia. And research is telling us that the median survival time from a diagnosis of dementia to death is approximately 4.1 years. And what we also know is that current available pharmacological interventions can neither cure nor reverse dementia and can only offer limited symptomatic relief. So there's an urgent need to be able to identify potential modifiable risk factors that could prevent or slow development of dementia as a disease. So what do we know about frailty? So frailty often goes unrecognised, so we can miss vital opportunities to manage the condition in its own right. Frailty is recognised as a potentially modifiable risk factor that could prevent or slow the development of dementia as a disease. And we also know that we have big gaps in knowledge. And having looked extensively at a number of publications, the accurate prevalence of dementia and frailty remains an unclear national picture. And that is due to the fact that in some areas, screening around frailty remains poor. So the reality is that dementia rarely travels alone, with stats showing us that in only around 17% of cases, a person will just have dementia. And available stats are outdated, they're constantly shifting, but for the purpose of this presentation, they are just helpful in order for me to show you an illustrative point of view. So percentages are naturally fluid and they will therefore constantly shift. But you can see from the slide that, the latest stats that are available, 41% of people also had hypertension, 32% depression, 27% chronic heart disease, 19% painful conditions such as arthritis. 18% of people with dementia also had a stroke or a trans-ischemic attack, a TIA, and 13% had diabetes. And other common problems included undernutrition and weight loss, urinary incontinence, urinary tract infections, hearing and visual impairment, generalized pain, and falls. So frailty is an independent predictor of mortality, and as frailty increases, a person will steadily become more and more vulnerable. And this can have an increasingly negative impact on the person's health and their ability to be independent. It's also important to note that frailty is not inevitable. Frailty can be medically complex and it can be inter-associated with multiple long-term conditions, but it can occur in the absence of these. Frailty is certainly amenable to treatment, and this is often referred to as modifiable stages of frailty that occurs in the early stages to mid stages of frailty. And unlike fragility, frailty is a specific syndrome with characteristic features and a rapidly expanding research base. So, frailty is a clinical syndrome characterized by a decrease in physiological reserves and increased vulnerability to stresses. And it's often associated with aging and involves multiple body systems. So, key characteristics of frailty include unintentional weight loss, exhaustion, weakness, slow walking speed, and low physical activity. And there are various frailty screening and assessment tools that are available to use. And these are often decided through your local guidance and your local policies. So a commonly used tool that I use in my own practice is the clinical frailty scale, known as the Rockwood tool or the Rockwood scale. This is a tool that we use within our core clinical services at Dementia UK to enable the nurses to be able to stratify the stage of frailty. And I've included a copy of this scale within the slide. You'll see that it's a nice visual tool to use. The clinical frailty scale, the CFS, has been shown to independently predict short, mid, and long-term mortality in a person. So it can be really helpful in order to stratify a person's level of frailty and then to be able to plan around their needs. So there are 3 stages of frailty. They are mild, moderate, and severe. So being able to assess for frailty can aid in planning healthcare and support interventions that include both proactive and reactive approaches to managing the person's frailty. It's also important to remind ourselves that in the mild to moderate stages, a person's degree of frailty can change. So it can shift up or it can shift down over time. And this situation becomes one of a more progressive nature as the person's condition advances. So sometimes a frailty syndrome will be the first indication of emerging and increasing frailty. And the 5 frailty syndromes are contained within the slide, and they are immobility, incontinence, delirium, falls, and susceptibility to side effects of medication. And the presence of one or more of these 5 frailty syndromes should raise the suspicion that the person has a position of overall frailty. So frailty can manifest uniquely in people with dementia due to the interplay between cognitive decline and deteriorating physical health. Common manifestations include increased risk of falls in the person, difficulties in performing daily activities, making the person increasingly more dependent on others, and nutritional challenges, and increased general dependency. So in our roles, we know all too well that hospital admissions can have a potentially negative impact for people living with frailty and dementia. And this can lead to increased mortality and readmission rates, with studies showing higher readmissions within 30 days of discharge for people that are also experiencing frailty. And also approximately 10% of all people attending A&E departments are living with frailty, with high levels of admissions occurring daily for falls, minor infections and adverse reactions to medications. And people over the age of 75 with frailty approximately occupy 20% of all our bed days, hospital bed days in England at any one point. And once admitted, there is a higher risk of functional decline in a person, delirium and increased confusion, hospital-acquired infections and related complications, alongside hospital-related harms such as pressure damage. We also know that hospital admissions can cause significant distress and anxiety to the person living with dementia and frailty and also to their carer. Alongside longer periods of inpatient stay, there is often a higher risk of change in both the person's cognitive and functional baseline on discharge that can often lead to a different discharge destination. And research and best practice is telling us that people living with frailty could often have their needs met better in settings outside that of acute care settings, such as hospitals, with potentially better outcomes. So there are a range of strategies for admission avoidance that I've included within the slide. So these include developing comprehensive care plans to address both the needs associated with dementia and the person's frailty. By undertaking proactive health monitoring to detect early signs of deterioration, by using tools like the Comprehensive Geriatric Assessment, CGA, to be able to evaluate physical, mental and social health needs. By taking an MDT multidisciplinary team approach to care planning and subsequent delivery. And when indicated, using a virtual hospital at home type of model to prevent A&E attendance in the first place, to prevent unnecessary hospital admission, or to be able to support an earlier discharge. And also engaging in advanced care planning, so to be able to plan for what is expected deterioration. And involving community support services to leverage community resources such as day centres, respite care and home care services to offer timely support. And this should also include education and training for carers to be able to help them manage symptoms and prevent potential crisis. And there are also strategies around addressing physical activity and nutritional need. Also around managing medications with regular medication reviews to avoid the negative effects of polypharmacy. So to be able to manage side effects, and also simplifying medication regimes where possible to improve a person's adherence to them. And offering psychosocial support and developing plans for rapid access to intervention or decision making around what could be a reversible or an irreversible issue. And this includes developing plans for escalation and sometimes non-escalation to hospital level care. I'm aware that this session hasn't got much time allocated today, but I put in national information on the slide, also in respect to incentivised improvements and policy initiatives, so that you can take a screenshot of them and you can research them. So frailty is typically managed through a four-stage approach. The first is to assess for frailty in the first place by using tools such as clinical frailty scales and scores to be able to identify and then determine the severity of the person's frailty. And that will then guide subsequent care and support strategies. And this should consider factors such as the person's medical, functional, psychological and social care needs, and should always involve the person and their caregivers during the assessment at the heart of everything that you do as a professional. The second step is to prevent and manage complications associated with frailty. And these may include, just to use three examples, falls. So you may implement a falls prevention strategy to reduce the prevalence of falls, to be able to manage the risks, manage fracture risk, and retain mobility, strength, and balance for as long as possible. The second example would be delirium, by implementing a strategy to be able to prevent and manage delirium risk and to be able to early identify when delirium occurs. And the third may be around hospital acquired deconditioning, by addressing deconditioning risks during a hospital stay to ensure a better baseline on discharge of functional and cognitive ability. The third step is to take a home first approach. And the fourth step is to undertake an holistic review. And this is referred to as a comprehensive geriatric assessment, a CGA. So through the CGA, a clinician will be able to assess underlying diagnosis, reversible causes, cognitive impairment, and long-term conditions. And following that, a care and support plan should be developed to address all of those needs. So in respect to managing frailty and dementia, you'll see that these overlap with preventing admission strategies. There are four key areas to managing frailty in dementia. The first is promoting physical activity and mobility to help to prevent deconditioning by retaining and maintaining strength, balance, and muscle mass, alongside enhancing a person's cardiovascular health. And this can be done through exercise programs, daily movement, and physiotherapy. The second is to ensure adequate nutrition and hydration. The third, addressing polypharmacy and reviewing medications regularly to ensure that they are fit for purpose and that there is no side effects from multiple medications. And the fourth is about addressing and providing for psychological and support needs. So there are a number of ways in which we can all collaborate and support in the management of frailty in dementia. By working together, we can ensure a person-centred, holistic care approach by keeping the person and their carer, wherever possible, central to all our decision making and subsequent care planning, by recognising personal insight and to recognise preference. Through providing education and training, so providing families and carers with the right knowledge and the skill to be able to manage dementia and frailty at home, helping them understand and recognise the early signs of deterioration with plans to manage the condition as it progresses, and to be able to escalate up support and care when it's needed. To ensure that adequate support networks are offered to carers. So your role, support groups and networks, even plans for respite care when needed. And finally, ensuring families have access to local resources, such as specialists, community services and healthcare providers. So today's session feels appropriate for me to share the paper boat story, which some of you will have heard of. The paper boat story was shared by Dr. Patricia Cantley as a touching analogy used to explain the concept of frailty in older adults. When talking to family members about their older relative, Dr. Cantley sometimes likens the person's clinical situation to a fragile yet beautiful paper boat sailing around on a pond of their choice. She recently wrote about using the paper boat analogy for a very elderly man under her care, who was going through a very complex and unstable time. At one point, there seemed to be a lull in the medical winds that were buffering his fragile frame, and she sat down with the daughter to chat things through. As daughter, she was desperately seeking reassurance, but was also wanting honest facts about what to expect regarding her father's condition over the coming months. She smiled as Dr. Cantley described the image of a beautiful paper boat, brightly painted and currently sailing proudly in the sunshine on a still pond, giving pleasure to all around. Dr. Cantley described to the daughter that the difficulty was not knowing what weather was ahead and the problems being forecasted accurately. If the weather was to remain fair with barely a trace of wind, then there would be no reason to think that the paper boat would go down. And indeed, it may sail on for quite a while. If, on the other hand, the wind got up, or worse, if it started to rain, the frail boat would go over. And it would go over quite quickly with little that they could do to save it. As younger and healthier individuals, we react more like tugboats made of wood and steel. We would simply bob up and down until the storm had passed. Though a big enough hurricane could be too much for us also. Dr. Cantley developed the story a bit more as she translated some of this into more medical language, and she formulated a plan over what would and wouldn't be reasonable things to try should the boat capsize over in a high wind. She agreed with the daughters that they'd want to try as much as they could do, maybe including intravenous therapy, but at the end, a call to the family rather than futile attempts at CPR would be the right strategy to take. She then noted this all down as a plan, and his daughter went away to update the rest of her family. As is the way with modern medicine, their paths diverged and the patient was discharged from the service. And Dr. Tricia Cantley didn't keep in touch, though she knew that his daughter had her mobile number and she could call if she needed to. Many months later, a text came through. Dearest Tricia, I am sending this sad message to you to let you know that last night the paper boat went down in a storm. It was all very sudden at the end, but we were well prepared, and for that, I thank you dearly. So I'm mindful that I needed to deliver within the 25-minute session time today. I'm also aware that I've given you an awful lot of taught content. I've put my details within the slide. I would certainly encourage you to contact the Frailty service. My colleagues' details are in there as well. Consultant Admiral Nurse Melissa Grundy. There are two of us that deliver the service between us. So it's been a pleasure to have delivered this session today. I hope that you found it valuable and helpful and giving you lots to consider moving forward. I've put in some references in the next slide. I'll give you a moment to just take a screenshot of those, and then I'll go back to my contact details so that you can take a screenshot of those too. And there are my details again. Okay, thank you very much.
So Henry is a 78-year-old man diagnosed with Alzheimer's 2 years ago. He lives on his own since his wife died several years previously of cancer. His daughter lives an hour away and visits regularly with her husband and grandson, and they have a close relationship. He's quite independent and manages well with some prompts to help with his memory. He was also treated for depression and anxiety after the death of his wife, and again after his initial diagnosis of dementia. He keeps active, he enjoys walking and still occasionally plays golf at the local club, and has a supportive circle of friends that he meets regularly. Apart from moderate arthritic pain and enlarged prostate, he is mobile and reasonably healthy. So while out for a walk, Henry stumbled and fell on the way out of his shop. The shopkeeper called the ambulance and about 2 hours later admitted to A&E. It seems he didn't have a fracture, but a nasty cut on his leg, and unfortunately broke his spectacles. As it was busy, it was a few hours before he was actually seen and examined in A&E. He'd been to X-ray and then moved to an assessment ward and then a medical ward for further treatment and investigations. His daughter was eventually contacted and arrived several hours later. But by the time she arrived, her father was agitated, confused, and very resistive to medical assessment and nursing intervention. And he was also prescribed benzodiazepine to reduce distress and agitation. So Henry ended up in hospital for 2 weeks, and during that time, his mobility reduced and his physical and mental health deteriorated and was discharged to a care home. The question is, what happened to Henry that caused his health to deteriorate so quickly? And perhaps you already have your thoughts. I'm going to stop sharing the presentation now and invite Jill to discuss Henry's case. Hello, Jill, and welcome.
Hi, Maggie.
So what are your thoughts?
Well, I'm just wondering, Maggie, what happened to Henry? I mean, how sad, just devastating outcome for somebody who was so previously independent and after literally a stumble and a skin tear, ended up becoming increasingly frail and assessed as needing full-time care. It does demonstrate, doesn't it, how people who have dementia are clearly vulnerable. So what happened to him, Maggie? How did he get into that situation?
Yeah, I agree, Jill. Really tragic. And unfortunately, this isn't an isolated situation, as there are so many cases like Henry's. We're all aware that people with dementia have an increased risk of frailty, but sadly, sometimes hospital admissions, a lack of understanding, and a sequence of events can increase those risks. So when Henry fell outside the shop, he initially was reluctant to go to hospital. He had some fears and bad memories of when his wife died. However, the shopkeeper convinced him, and he had a painful leg, which, although was due to a cut, it was hard to tell whether he'd sustained a fracture. So when he waited a couple of hours before the ambulance came, and then a couple of hours before admission to A&E. And in that time alone, he had nothing to eat or drink, and no one with him to get him anything. I think at that point, he was really quite anxious, but able to explain what happened and provide details. He didn't want his daughter contacting at that point because he assumed that he'd be going home soon after he'd been seen, and he didn't want to worry her.
Oh, okay. I mean, A&E can be busy and noisy, can't it? And unfortunately, there's always a lot of waiting around. And of course, he'd broken his glasses, so that wouldn't have helped at all. And then, of course, he went to X-ray and then back to the assessment ward where I assume his leg would have been dressed. It sounds reasonably straightforward. And once his leg was dressed, he would have been discharged with antibiotics. You would have thought anyway.
Yeah, no, I know you would really, wouldn't you? I mean, it could have been that straightforward, but this was now 5 hours later, and Henry was starting to develop a delirium, which we know can come on quickly. And given he had an infected wound, was probably becoming dehydrated, and hadn't got any analgesia offered for the pain, his arthritic pains, and a diagnosis of dementia, all made him really vulnerable. That and the fact that he was moved several times, his spectacles, of course, had broken, and then an environment was quite chaotic, added sort of further risks of a delirium and acute confusion.
Okay. So why was he given a benzodiazepine then, when we know that increases confusion for people with dementia?
Really good question, Jill. I mean, using antipsychotic medication or benzodiazepines in people with delirium has a potential to increase confusion. Henry became very suspicious and reluctant to have any interventions carried out, which is often the case when people have a delirium. He became very anxious and distressed, and when the doctor read Henry's medical notes and saw he had a diagnosis of dementia, assumed that that was the cause of his behaviour. They hadn't seen him when he initially arrived at A&E, when he was lucid and had capacity and was able to articulate, his needs and what happened. So he was sedated. At that point, his daughter was contacted and arrived 2 hours later when Henry was moved to a ward. I mean, she was so shocked and very upset to see him that way.
I'm sure. It makes me wonder, if Henry didn't have a diagnosis of dementia, would they have recognised it was a delirium earlier? Or perhaps would staff assume that because he was of a certain age, he'd had an undiagnosed dementia?
Yeah, I mean, that's interesting, isn't it? And it's a possibility. I mean, his daughter did speak to the staff and explain that the behaviour they were describing was not his father. It was not her father, and he was a gentle soul who was independent and managing well before his fall. Problem was, they didn't really listen and put it down to advancement of dementia. I mean, as frustrated and upset as she was, she assumed they were the experts and knew what they were talking about.
That must be so difficult for families, when they know the person so well, but they don't feel like they're being listened to by the professionals. We know it's not normal for someone with dementia to deteriorate so drastically within a few hours, without some underlying cause anyway. So what happened then, Maggie?
Well, I think over the next week or so, he wasn't eating or drinking much, but his daughter was able to sort of visit and help and encourage him. And because he was sedated and his arthritic pain increased, his mobility reduced. I mean, as mentioned, he had an enlarged prostate, which previously caused him some frequency and urgency, but not real issues. But due to his increased confusion, had episodes of incontinence. His overall health just deteriorated and became increasingly frail, hence the decision and need for full-time care.
So what do you think might have helped and prevented Henry's sudden deterioration like that?
I think, unfortunately, like most things, it does come down to understanding and communication and information being passed on from professional to professional. When the ambulance picked Henry up, and when initially he was admitted to A&E, he was fully alert and able to answer questions and share details. Then he was moved several times to different teams, and that information not necessarily passed on. So each time he was seen by a different team, he was deteriorating. Ideally, on admission, an abbreviated mental test, AMT-10, or similar cognitive assessment could have been carried out, and that would have provided a sort of a cognitive baseline so that any deterioration could have then been identified. I mean, there are also several delirium assessment tools, including the CAMS, which help to identify if there's a sudden change in a person's behaviour and presentation, which can be helpful to determine if a delirium is present. I mean, we know that older people are more susceptible, and they are up to increased frailty, and how people with dementia are at higher risk from a delirium. So ensuring they receive the basic needs, fluid, food and pain relief are so important, particularly in the absence of family members. I mean, also providing reassurance and just explaining what's happening can be really helpful, because he was quite frightened.
Yeah. I mean, it sounds, doesn't it, like it would have been really helpful to have had an advocate or a specialist health professional who could identify and support potentially vulnerable adults, particularly those living with dementia, and just to ensure that they're seen quickly and treated and then discharged safely.
Absolutely, Jill. I mean, it's difficult to know how, the outcome would have been different, but so often people like Henry spend unnecessary lengthy times in hospital and discharge often delayed. I mean, your suggestion to have someone to support during admission would be great, wouldn't it? It may seem unrealistic, but would not only reduce the risks of people becoming frail, but also unnecessary distress for the person and their family, not to mention bed occupation and huge amounts of money. Yet no one knew Henry or were prepared to listen to the person who did.
Oh, okay, thanks, Maggie, and thank you to everyone who's listening. It certainly demonstrates, doesn't it, how people with dementia are at increased risk of frailty, and how us as professionals can reduce the risk for people living with dementia.
Absolutely. Thanks, Jill.